We now move to an interactive highlight of the day, our Meet the Expert session. Here we connect directly with some of the leading minds in trauma surgery and emergency care. This session will give delegates the opportunity to gain wisdom through real-life experience, clinical insights and lessons from the field. We now warmly invite on stage our moderators for the session. Dr.Chathura Karunatileke, Consultant Trauma Surgeon at National Hospital Sri Lanka, Dr. Viraj Rohana, Consultant Trauma Surgeon at the National Hospital Sri Lanka, and Dr. Sajith Ranatunga, Consultant Trauma Surgeon at the National Hospital of Sri Lanka. We also invite our panel of experts to join us on stage. Dr. Rueben Peralta, Deputy Trauma Medical Director at Hamad Medical Corporation, Professor Jeremy Shue, Clinical Associate Professor at University of Sydney, Australia, Dr. Mark Fitzgerald, Director, National Trauma Research Institute, Australia, and Dr. J. Gunatheepan, Consultant General Surgeon at National Hospital, Sri Lanka. The subsequent case discussions will be presented by registrars in surgery. We now invite them to commence their presentations.
So we would like to discuss three case scenarios here. For the first case scenario, Dr. Purna Godakanda, a trauma unit registrar, will present the case now.
Good evening, and we are moving to the first case. Actually, it was a case of multiple gunshot injuries, and moving forward with the case, it was the 52-year-old male brought to the A&E by the police and the ambulance crew, and it was after sustaining multiple gunshots approximately 30 minutes after the incident. So on admission to the hospital, National Hospital of Sri Lanka, patient in the airway, patient could not communicate, patient was gurgling, but blood inside the oral cavity. And saturation was maintaining in the 90 and the respiratory rate was 25, with the left-sided air entry was reduced. Blood pressure was 90/60, with the pulse rate being 110, with it was low 3D volume pulses. GCS around 14 and patient was confused, and pupil bilateral equal and reactive. And in the exposure we noted there was a large hematoma of the right side of the neck with the entry wound over the right posterior triangle. No exit wound were appreciated at that moment. Apart from that, there was another injury in the thorax with the gunshot entry wound over the left side back of the chest with the trajectory towards the anterior axillary line. That was the case that we got in our hospital, and with the slightly distended abdomen with left upper quadrant tenderness. So moving forward with the discussion, what are the possible injuries would you anticipate on this patient according to the description that we have given above? So I would like to ask that question from our expert panel. What will be the injuries?
Here I would like to initiate the discussion. Like he said, the injuries were, there was an open injury into the right side of the neck, and there was another injury to the left side of the body. So injuries can happen anywhere in the body. It's a gunshot, multiple gunshots, and he was shot behind the back. So it can be either on the right side and the left side. So we actually anticipated injuries, chest and abdominal injuries. It could have been anywhere in the body. So basically, the neck injury involving probably the laryngotracheal, upper airway and the pharynx. Plus, on the left side, we were anticipating chest injuries, cardiac injuries, and diaphragmatic injuries. The reason is the way he was shot, he got multiple trajectories. He was shot from the back, and there were entry wounds on the right and entry wounds on the left.
As explained, we were suspecting whether there's neck injury, chest injuries, or the abdominal injuries. And in the neck injuries, whether it is a vascular, tracheal, laryngeal, or cervical spinal injury. In the chest wise, there is a tracheobronchial injury, lung injury, pneumothorax or hemothorax. Going to the abdomen, whether it is a splenic injury, diaphragmatic injury, stomach and bowel injuries. So with that things in the mind, while resuscitating and assessing the patient started coughing up the blood, and the respiratory rate has gone up to the 45 from the 25, and he developed stridor and the hoarseness of the voice and notable large hematoma in the right side of the neck. And how would you secure the airway patency? That was the question we asked, and it is open for the experts.
Okay. This case actually almost all part of the trunk and the neck is affected. But we are strict on the principle, right? First, we are secure the airway, that is our first priority, because that large hematoma also there. If it is possible, first you can intubate these patients, or if they are surgical, depending on the injury, surgical airway. What is the situation on admission? Is it necessary for any surgical airways?
Mr. Chairman, I think I'm suffering from the triple S syndrome. Spicy Sri Lanka food syndrome, okay? We have exposed the patient, we know where the injuries are, where are the holes, we're just guessing here. We need to expose the patient, where the holes, how many holes we have.
Yeah.
All of this table of the injury could be possible, and we know that. But we need to expose, compassion care, we have to expose this patient, okay? Thank you.
As explained, it was a definitive airway.
I guess it varies from hospital to hospital, but when these patients arrive at our hospital, there's people already scrubbed. So you have the trauma people already scrubbed, and the anaesthesiologists and emergency doctors, and we prep them from above the clavicles down to below the ribs. And depending on what the issue is, but it sounds like his airway is the major issue, then there'd be an attempt to intubate the patient, but if it fails, he's just going to have a surgical airway. But at the same time, you'd be decompressing the left chest. At least if it's a big pneumothorax, we just open the chest.
And the questions were the patient...
Sorry, can I just add something? Is there something? I actually think, like what Dr. Peralta says is the key principle. That's certainly what we would do. Like the gunshot wounds, multiple gunshot wounds, the principle is like ensuring that you know the trajectory, the wounds, because the key thing is to identify basically from a surgical perspective which cavity or cavities you may need to enter. This patient is really unwell. Everyone said this is the airway. Already from the initial information, this patient is not doing well, right? So like from a surgical perspective, this patient is dying. And so you need to know where it is. And many people with military experience know that like part of it, a lot of places they do a blood sweep. They run their hands behind the patient to see if there's any like obvious big blood that's there. Obviously in a hospital, you quickly, and what we teach our trainees is that exposure becomes higher in that order than with blunt trauma, because you've got to know where the wounds are so you can work out the trajectory for that.
Another thing, I may not intubate this patient very well unless I decompress the chest, because I can kill it right there. As soon as I intubate it, put in positive pressure, this gentleman may have tension pneumothorax right there.
So going with that discussion, whether the patient needed an airway. As explained, we inserted the endotracheal tube, and the question for the experts are whether there's a place for an emergency tracheostomy with a gunshot wound over the right side posterior of triangle of the neck with enlarged hematoma.
This decision for endotracheal tube or is a tracheostomy tube. It's a injury is involved, the anatomy of the injury. That's a decision making. We have to take that one. That is a technical issue, right? If it is a injury, unable to intubate any difficulties, that is safely you can go with that surgical issue. Any other opinion?
No, I probably not do tracheostomy in this patient. I probably do a tray, cricothyroidotomy, because by the time that you set up the things, it's too late. This patient is, is crashing in front of you. And you see, this is what I tell you, medicine is an art. Every protocol has a discretion of the consultant or the senior there. If you go to the C in this patient, ABC, which was presented here, this patient is in heaven. It's gone, okay? You have to make sure that you have to get the airway quickly in this patient.
What are the precautions when attempting, your precaution when attempting to intubate at this difficult situation? Because we know that there was a blood pooling inside the oral cavity.
No, thanks a lot. Well, the number one thing is he's probably going to rest as you're trying to intubate him. So you have an experienced person. We don't use inline stabilisation. They can paralyse the patient, but if they can't get a tube in, they can use an LMA and then you can go on to a surgical airway. But you've got to discuss this before there's an attempt to intubate the patient, so that everyone's very clear of what the cut-off line is. And we use a saturation of 70% or less for a surgical airway, and we use a systolic blood pressure of 70 or less to open the chest. Now, I know that's only a guide, but it becomes a decision point then, and everyone agrees to it and sticks to it. You see people desaturate, and I'll just give me another go, or I'll just have another attempt, but you don't allow that. You just have these cut-offs.
This patient was intubated with the help of the video laryngoscope. So he was intubated with the experienced person, an anesthetist in the room with the help of the video laryngoscope. There was blood inside the mouth, so there was possible tracheobronchial injuries and possible pharyngeal injury at that moment. But we were able to pass a tube safely.
Now patient is intubated. Should we have a high suspicion of diaphragmatic injury?
What happened when you went to intubate him?
Yeah, we are moving on.
I wouldn't care about a diaphragmatic injury. It's not going to kill him at the moment. I want to know, was there displacement? Was there a big hematoma?
Yeah, there was a hematoma, but it was not expanding. It was static at the moment. Sorry? Since we got the patient, the hematoma was persistently same in size in the naked eyes. And the patient was intubated through a experienced person. Actually, the anesthetist was present at the room. Then saturation was maintaining in the same value, around 90 to 92, but the blood pressure was around 190 at that moment, if I'm correctly remembering the facts. And despite being said that, I say that the air entry was reduced in the same side, left side, with the gunshot injury to the left side chest. And our suspicions were whether there is a hemothorax, whether there is a pneumothorax, and should I think about a diaphragmatic injury on that same patient, because the trajectory was towards the left side anterior axillary line.
If he has not coded by this time, it's because he has a diaphragmatic injury. Because he would have developed attention pneumothorax if you already have a gunshot wound through and through, to the left chest. And that's what I asked. I like to see the diagram of the bullet to see, to have my, I have a little reading disability, but if I see the holes, I know what to address, plus the physiological status of the patient.
Yeah, I'm sorry, I couldn't.
I know. It could have also massive hemothorax, hemopneumothorax. You put positive pressure ventilation, this patient will collapse.
And going by that, I will show you the X-ray which was taken on our room actually. And it was showing left side hemopneumothorax with the left side diaphragmatic possible injury with the positive fast which showed the perisplenic free fluids.
Sorry, I thought you said he had a massive left hemothorax. So how much blood's come out of his chest drain?
So, yeah.
No,
So,
at this moment still we haven't introduced our chest drain. We were planning to introduce our chest drain. Since there was a diaphragmatic injury, we were in a doubt whether we should go with the chest drain. As for the usual, we say we go by the 5th intercostal space, but we were thinking whether we should go above that, since we were thinking about the diaphragmatic injury. And other question was whether this patient needed gastric decompression before the IC tube. That was a question we were raising in for the experts. And the things that we have done was that we have introduced the IC tube anyway.
Probably compressed by the bullet. You're not giving any type of fluid to give in this patient?
Yeah,
what is your
resuscitating?
resuscitation?
Same times we were resuscitating and we could get down
With
the
what?
blood.
With
the
what?
bloods.
Okay,
With the
good.
blood. O negative blood was ready by the 10 minutes time, but the group specific blood work came around 20 minutes later. By the time we were doing these things.
Can I ask?
Yeah, sure.
So you've got one hole.
Yep.
One hole or two holes? So you have 3 holes altogether.
Yes.
And did you put, I couldn't see the markers. Do you put markers on the X-ray? I
No.
just couldn't see that. Like if you go back to the,
no, we haven't, no.
yeah, because I would just suggest that we normally put markers over the holes just so that we get an idea about where exactly it's the trajectory. And then the other thing is that you're still, just as a general principle, you're still missing like something. You haven't found the bullet because you've got 3 holes and there's no bullet that I could see on the chest X-ray. And so I would still be worried, where is that? Has the neck one gone all the way through? I don't know.
Yeah, so what actually happened was we were focusing on the airway, we were managing the airway, and once we got the airway in, the saturation was not really picking up, and then we came to know that there was another injury on the left side of the thorax, going through and through, and it was going through the left side of the chest and coming out in the trajectory towards the anti-axial line, and then we suspected that they should be going towards the diaphragm, and because the fast scan was positive for perisplenic fluid, and later on he had an IC tube on to the left side of the chest, and but before that we did a chest X-ray. So the IC tube was placed after the chest X-ray. So we did the chest X-ray first, then had the IC tube.
But where's the bullet?
Or just gone through.
As in
the chest one has gone through.
2, 3. Yeah. You still have 3 holes.
Just one bullet has gone to the left side of the chest.
I would be very worried. Me personally, I would be very, very worried because generally, it should be an even number. Holes plus bullet should kind of be an even number, just as a general rule. Anything's possible, right? But I would just be very worried if I to call it all just one.
Yeah, there's this famous story out of the Iran-Iraq War of a man who presented with a bullet wound to the right side of his neck. And in fact, the bullet had gone down through the right side of his chest, through his liver, and ended up in his pelvis. I mean, he survived, but I don't know what the mechanism is. Was it a sort of close range shooting? Did someone come up and try and execute him like the Romans did with the sword, shooting downwards? I've got no idea. And the second thing is, it's just terminology. For us, massive hemothorax is when you take the initial chest X-ray, there's no air on that side of the chest. You know, you've got at least 2 litres in the chest. So I misunderstood what you were saying, because for that we just open them up. But if he's got a hemothorax, it's quite different. So I guess that's the issue I'm interested in.
So the question actually we were discussing with the airway. Now the breathing we have introduced an nasogastric tube and the IC drain to the chest left side. And the problem is, will you consider surgery in all diaphragmatic injury patients, since there was a diaphragmatic injury we have explained in these patients?
I guess you put a chest tube already, no? How much is the chest tube out? Put? I couldn't hear.
It was size 32 French. 32 size French. We went, usual we were going at the 5th intercostal space, but we went over the 4th intercostal space. In the meantime, the anesthetist put the NG tube to decompress the stomach. So anticipating that fact in our room with the facilities provided in our country, so we could do all the things. By the time that we noted that there was a diaphragmatic injury as well, since there's elevation of that stomach to the left side of the thorax. So now the question was arising in our mind as trainees, whether to consider the surgery in this patient at this moment, and should I repair this patient's diaphragmatic injury despite its being the grades being 1 to 4, or what was the timing of the repair?
So just saying, how much was in the bucket and the chest tube?
Chest tube.
1 liter, 500, 400?
No, it was around 700, sir. 700 milliliters of blood. It was pneumothorax, and we were transfusing with the bloods, and we could transfuse 2 pints of the blood. Blood pressure was maintained to the normal range actually, systolic be in the 100. And at that time, we were thinking whether to go ahead with the surgery, with the diaphragmatic repair, or whether to go ahead with the CCT neck, chest, abdomen to delineate the anatomy of the trajectories of the wound which happened in the neck, which happened in the thorax and the abdomen.
Tube is continuously, is the bleeding, is a major bleeding is ongoing, or is it stopped?
After the initial drain, say it was not bleeding actively.
That hemodynamically is improved with the...
Yes, hemodynamically patient was improved, sir.
Right.
And the question for the expert panel, and will you consider surgery in all diaphragmatic injury patient, and what will be the timing of the repair?
I think what we're trying to say is that you know what the problem is with the patient, and you know what the end result is.
Yes.
And you're steering it to the end result, but we're still trying to get there and working our way through what the injuries are. And we don't really care about the diaphragmatic injury at the moment. That can be done tomorrow. We just want to make sure that the other life threats have been removed. So, but you've sort of gone forward in time, like Back to the Future, and you're a day in front of us at the moment.
Yeah, because I still am not sure whether I'd be happy, as I said, take the bullet thing aside, but if you're saying that the abdomen, you said that there's a positive fast.
Yes,
I mean, we
positive
don't use
fast.
that.
Positive fast.
Yeah,
with the
we don't really use it. But anyway, if you say that there's a positive fast, we would probably just operate. And if you see the diaphragm, sure, we can fix it. But I'd be less worried about the diaphragm and more worried about what other potential injuries there are in the abdomen, like small bowel, stomach, etc., all that like kind of thing. So I guess that's where, I mean, I agree with what Mark is saying. Like, obviously there is something that you found, but from where I know of this case up to this point, I'd be worried that there's intra-abdominal injury.
Yeah, can I get this way? So there is penetration, so it's a gunshot. Obviously, we had to go in and operate. So he had a laparotomy. So what we want to discuss is whether, for the trainees, in case if there's a diaphragmatic injury suspicion, will you operate on all the diaphragm, irrespective of it being a gunshot, blunt trauma, perhaps. So do we operate on all diaphragmatic injuries? If so, and what type of injuries would you consider operation, and what's the approach, thoracoscopic approach, laparoscopic, thoracic or open. So that we want to discuss with the experts.
Good.
Yeah, that was the
So my
practice.
colleagues are there in the first row. If I get more than 37, 45 minutes in the trauma bay, and not knowing the OR, they're gonna punish me tomorrow, okay? So we have to move quickly to the theater or to whatever you want to do it there. And this patient, if he's still maintaining blood pressure, if you have fast posture, you have to go to the abdomen first. Now, it's no crashing. Now, it's another way to do it. If you have reboa, you can put a reboa, go to the abdomen first, and then you're trying to stabilize the chest later. But if this patient crash, you have to go to both, and especially to the chest to do that if you don't have reboa. Right now, the best thing for this patient, forget about this laparoscopy thing, we should take it out of this list, it should go open, okay, in this patient. Laparoscopy, diaphragmatic injury, all of these things, is a really almost a negligent type of case, or lack of knowledge type of case, okay? To be careful.
So in which situation would you open up the thorax and repair the defect through the thoracoscopy, thoracic approach?
In this institution, the patient is still fluid dependent and start with the abdomen. We prep from neck all the way to leg. We start down and we continue.
Yeah, and the other thing is, I want to know where was the wound in the neck? How low was it?
It was left side, right side posterior triangle.
Sorry?
Posterior triangle of the neck, left side. Entry wound was there.
So where was the hematoma exactly?
It was expanding from posterior triangle towards the anterior triangle, but we could palpate this thyroid cartilage from our hands, even despite being there as a hematoma.
So these pupils were equal, so you weren't worried about the
Yeah, actually we were
anterior
worried
circulation?
about the neck injuries as well, sir. I will be discussing in that patient, but the thing was we were addressing the diaphragmatic injury. We went through, we did the laparotomy and we repaired the diaphragmatic injury. We did the bowel survey. There was only capsular tear in the spleen and this was not a massive bleeder. We repaired the diaphragmatic injury on the spot, sir. And later we resuscitated the patient again in the ICU, went ahead with the CECT, neck, chest, abdomen, and delineate where was the pellets were, then approach to the neck later. Sir. That was actually I was happy to say that patient went home.
That's with regards. I mean, that's great. That's good. That's you ended up doing like what I think I would have done, which is operate and do the laparotomy. But I think with specifically this question about diaphragm, most of the time in the emergent setting, you're going to go from the abdomen, and you will repair it, like particularly if it's in the central part. I think the thoracic approach, the only time I've ever done this is actually with chronic, like as in delayed recognition of the diaphragm injury, and now there's herniation. Sometimes you've got to go from both. That's in my experience, just because often with these chronic ones, they're stuck, and there's adhesions like up there, and there's bowel and momentum and all sorts of things, and sometimes it's easier to push it down. And that's been my experience. Like I've never repaired a diaphragm injury except for a diaphragmatic intercostal rupture. So that's blunt trauma, as in on the right side. I've repaired that by fixing the costal margin and then repairing it from the top. But I knew what the injury was already. It wasn't penetrating like this.
Yes.
And then I think the laparoscopic, in our center, we use laparoscopy if there's just for stab wounds. So if it's a thoraco-abdominal stab wound that the patient is otherwise fine, we will put in a laparoscope to evaluate the diaphragm, like as in if they have no other signs of injury.
Yes, performance indicators are, you have rules for this thing. You have the stomach herniated, you have to decompress. You cannot wait, 2 days or something. You may herniate necrosis and you lose the patient. It's right there in front of you. And I think the best way to do it, and when we are with multiple holes that we don't know, is go through the abdomen.
In this case, that's important that continuous intercostal drainage bleeding, then his approach should be the thorax. Is it right? If intercostal tube drainage is continuously bleeding, his approach is a thorax, or is a both. Definitely abdomen we have to go because that injury is in the up. the diaphragm is damaged, that should definitely exclude the all abdominal injury damage. But if bleeding is ongoing in the thorax, then it's a approach should be both.
Let's see how my colleagues say. I will go physiological. I will go to the abdomen first, because if he has a big hole in the diaphragm, could be the spleen or the liver, or even the aorta, that we have cases like that. He survived also. Execution at style. Sometimes I'm confused. You say we are in Colombo, I thought you were in Colombia, South America, eh? Because it's a lot of gunshot wounds like this. Eh? Those are execution style that happen. We have one patient, our colleagues were there with us, an incredible save. We use everything, Riboa, things, aorta through and through. But, we were in the OR, eh? We were fast. Those people will know way to things. I tell you, I think the best way is also, how about injury, contamination? You have to address all of this issue. I cannot address with the FAST. FAST is not reliable for this at all.
Excuse me. I think one of the comment to Dr. Gunatheepan, I think we can go even thoracoabdomen incision in case if you both area is involved, you are suspecting open abdomen thorax. Continuation of the same incision through the thorax.
Yeah, I think that you're like, these are all, they're not super common, and thoracoabdominal is always two cavity that you're going to have to worry about, and which one do you go through first. It's a little bit artificial because, if you open one bit and you don't find much, you can open the other cavity, right? Like that's a practical aspect to it. And so the data would suggest that you probably get it wrong about a third of the time, particularly on the right side. So like say large output from a right-sided chest drain, right-sided penetrating injury, there's a good chance that it's bleeding from the liver, right? And so if you just go on the chest drain output, you might get it wrong. But, as I said, I think it's all great in books and pictures and stuff like that. But I think at the end of the day, it's the physiology, and you just have to make that guess about, and that's why knowing the trajectory is important, and knowing that's what I think. And as I said, as long as you're prepared, you make that decision and you say, okay, I think that we're going to go on the abdomen first. And you have a quick look and you don't find much and you see blood coming down from the chest, then you got to be prepared that the chest is already ready to go, kind of like what Mark said. If you're already prepped, ready to go, get in there quickly.
I guess it depends on your institution as well. So because we've got this large cardiothoracic service, and we've got a lot of the surgeons are full-time, all but one of them are full-time at the hospital. Yeah, for cardiothoracic surgery. So it's easy for us to get cardiothoracic surgery. So we'd have a very low threshold in the emergency department to do a left anterolateral thoracotomy. You'd see the diaphragmatic injury, you'd deal with whatever's in the lung, and then the general surgeons would be getting ready in theatre, and then we'd take the patient up the OR without having to worry about the chest. But if you don't have that service, then I guess you have to have a different approach. But I don't think either's right or wrong. It really depends on what the most efficient system you've got is.
So yeah, we like that approach because we do have a cardiothoracic surgeon on call on site 24 hours. So thank you for that wonderful insight and new knowledge for us. So we'll move on to the next case to cover some other areas.
I'm inviting my colleague, Dr. Surage.
Listen, let me congratulate you for this incredible case. Dan didn't read the book, and you were really nice and brave to present it, This is great. This is the art of medicine. You did it where you have, but I tell you, go through the chest next time, okay? Go through the abdomen next time quickly. Thank you.
Thank you, sir.
So moving to our next case, it is a blunt abdominal trauma. So, this is a 44-year-old male patient transferred from Peripheral Hospital to the NHSL following a fall from height about 15 meters. Incident was occurred in midnight and patient was brought to the peripheral hospital within 2 hours. And with the initial resuscitation, patient was transferred to the NHSL. In the NHSL, we assess the patient according to the ATLS protocol. The patient's airway was patent and the bilateral air entry was equal with the saturation of 95 and patient was a little bit tachypneic. And patient was in shock with the blood pressure of 65 by 48 and he is tachycardic with the low volume pulse. We started red cell transfusion and after transfusion of 3 units, blood pressure pick up to the 160 and disability wise patient GCS was 14 and the bilateral pupils were reactive. And during our exposure, we noted that there is a left loin bruising with tenderness over the right hypochondrial region and the suprapubic region. So then we did the PAS scan. It was positive. There is a moderate amount of free fluid noted in the perisplenic region, and chest X-ray didn't reveal any pneumohemothorax. And chest X-ray revealed there's a left side inferior AMI fracture with acetabular fracture. So we'll move into the question part. So according to the history, what are the possible injury would you consider in this patient? We'll ask from the expert panel.
Well, thank you for being brave also. You know, I don't care about the injuries. I'm going to the OR in this patient, okay? And I find out the injuries there. I can tell you a list of injuries, spleen, liver, mesenteric. But I tell you, this patient is not responding to 3 units of blood, 65 over 25, heart rate 131, fast positive, performance indicator, you need to go to the OR, okay?
This patient actually with initial fluid resuscitation with blood and hemostatic resuscitation, his blood pressure became stable, maybe around 100. So in that case, we didn't go to the theater immediately, so we took the patient to the CT department and we got this CT scan done for this patient.
Right. So what is your best management option or what is your best approach to manage this patient? So we'll ask from the...
Yeah, that's I think we discussed. So he initially responded. I mean, it's a transient. He's a transient responder. The CT department was like getting a CT scan done. Was getting it done about 1 minute. So 1 to 2 minutes, we could have get a CT done. So we did a CT scan on this patient, and then within 2 minutes we could have taken the patient.
We take 25, 30 minutes, and I'm there, on top of the guys, okay? Because we have CT gated, we have to do so many technology that because we want perfection, and shouldn't be perfection, should be excellent and good. You know, we have all of these gadgets that we put, and by the time, you know, it's 30 minutes, 25 minutes.
Yeah, I'd be interested to hear what happens at the Alfred as well. But certainly for us, we have like time to CT as a key performance indicator. And so for, you know, patients multi-traumas, like we actually want them within sort of 15 minutes from the time of arrival. But I can tell you, once they get to this, even though our scanner is just, it's in the resus bay, it takes like about 20 minutes in the CT room, like as in all together. I'm not sure at the Alfred.
No, it's exactly the same. We've got 2 CTs and 2 MRs, you know, 10 metres away. But no, I mean, by the time you do the transfers and everything, there's a lot of mucking around. And we haven't got it yet, but our solution is we're building another operating room next to the trauma bays with a ceiling mounted CT in the facility. So you can scan the patient while you're doing initial reception, but we haven't got that at the moment. You know, stop the bleeding.
Yeah, from the there are some papers where there are some papers that have been produced where to show unstable patients benefit more from a urgent CT rather than a stable patient. There are so many unstable patients who would benefit from, while that means you are not going to send the patient away and sit back. You are resuscitating while doing the CT. So that sort of CT scan will benefit unstable patients. I can't give the papers offhand, but there are several papers who have come up to say that unstable patients benefit from CT even without the total resuscitation.
But I have, we belong, we go a lot to the European community. We go to Estes. I have a lot of friends from there. And Qatar has a delegation, usually 11 to 15, colleagues and like 30 presentations every year. But I tell you, if you're in Zurich or Germany, they pan CT even you don't have a blood pressure. But this is not the real life, okay? So they have a lot of incredible things. They have the CT right there. They have the 1 minute stop. They have, it's like the German car. They have a lot of things. But I tell you, if you are traumatic bringing your pupil and blowing, and you're trying to really stop the bleed as much as fast as you want it, okay? Trauma registry, most of the story from this one come from trauma registry and penetrating now from Colombia, from Cali. We do a lot of things like that, but all of our staff are trauma and critical care trained. All of the staff. So my last patient with 2 vasopressors were in the CT scan, but I tell you, I lost 10 years of my life.
I mean, the advantage is this patient sounds like just a blunt trauma patient. Yeah. So obviously the scanning's going to help, but I'm very cautious about these pooled studies because it's very variable, institution to institution. So you can go to some institutions and the surgeons can do pretty much everything. They can open the chest, they can open the abdomen, they can get retroperitoneal access, control the vascular structures, they can decompress the skull. While in other institutions, the surgeons are super specialised. And, so it really depends on the facilities that you've got in your institution. I mean, we try and scan this patient at ours because the CT's there, and occasionally you have to bail. If the patient's not responding to ongoing resuscitation, you just cut your losses and get off the scanner. But it really depends on what your institution does because there's quite a lot of variability depending on the expertise of the staff and the proximity of the ORs and such like.
So, however, because this patient has transient response, we did the CCT abdomen and pelvis. So, these are the CCT findings. There was a mild hemoperitoneum and there was a grade 2 splenic laceration and massive gastric dilatation also. Then there was a large left side retroperitoneal hematoma with the possible of renal injury, and there was a pelvic hematoma with active extravasation, possibly from the left obturator artery, because he had the left side inferior rami and the acetabular fracture. And these are the CT findings. So next question will be, so how would you decide whether to go for operative or non-operative management in this patient?
This case you can't operate at the moment. It's a very operative. It should go for the non-operative interventional radiologist. The arterial flushing is there. Yeah. At the same time, you have to put that on pelvic binder and pelvic stabilization. The outside is the first. At the same time, during the whole process, you maintain that hemodynamical stability with that all your resuscitation. Here is this case is extended resuscitation is essential. Is continuously is bleeding, the patient is very unstable. But if you are opening in this case, going for the operative is a disaster to the patients. Very minimal interventional measures we have to make to that bleeding.
I think one of the key points is what does the CT brain show? Because if the person's got any intracranial hemorrhage, we're going to embolise the spleen, even though you could probably get away with not embolising it. And because of the pelvic fracture, the person's going to be at risk for, at least in our population, of DVT and pulmonary emboli. So at our facility, you'd have some temporary splinting. they'd go for angioembolization, they'd have the obturator artery embolized, they'd have proximal embolization of the spleen, they'd have an IVC filter put in, and then they'd go to the OR for pelvic temporary stabilization.
The problem was we tried to contact with our intervention radiologist, then there was an ongoing CT angiogram, so we couldn't do the CT angio and embolization for this patient. That's the problem we had at that time.
That was my question to ask you. You know, it's a great presentation. I think it's nice to put the time of the patient arrival. If it's a holiday, if it's the Sri Lanka National Day, then everybody's on the beach. You know, all of these things, if you have 24/7 availability like us in 20 minutes, you know what I mean, things like that. If the patient has severe traumatic brain injury or no, you know what I mean, all of these little things, coagulopathy, coagulation derangement, to see where the physiological will drive us to do something else. But if you don't have CT angioembolization, I will not do CT in this patient because I have to go to the OR. You see what I mean? You save money to the hospital and you learn to operate. You know, we teach the residents how to operate. You see, this is logistic. That's why my team told me, oh my God, this guy is like playing chess. If I don't have this ability, you go to the easiest one. Anyhow, you know, you do something, and you have to CT scan of the patient, but you CT scan this patient when it's controlled bleeding.
The only thing, like if you go back to the findings on the CT that you have there, you know, the interesting thing is that none of that, like I don't know what that left side retroperitoneal hematoma is, whether that's coming out from the pelvis or not, but you know, left obturator artery is a little bit unusual. The fracture pattern that you described is not really associated with massive, like kind of pelvic bleeding, right? Not to say that it can't happen, but I just think sometimes if you don't have interventional radiology, actually what we found, certainly over the last maybe 10 years, is that the change in resuscitation, I'd be interested to hear like from the others of whether they've observed the same thing, like it's like Back to the Future. Like they used to say with exsanguinating pelvic fractures, like back in the 70s, that this is where that surgical dogma of never open a retroperitoneal hematoma came up because they all died. And so there were papers that were written just to say, you should just keep resuscitating them. And actually, what we've found over the last maybe 10 years or so is that with our resuscitation, you know, close component therapy, you know, that we just don't see people kind of exsanguinate really anymore from the pelvis, from the pelvic fractures. And I would bet in this case, if you had like good blood product resuscitation, this patient's going to be fine without anything.
We noticed, we get 250 major pelvic injuries a year, and the mortality's gone from 25% 12 years ago down to 6 to 7%, and people don't die from their pelvic injuries. And there's a couple of things that happen. One is people stop using normal saline, and secondly, just blood, concentrated red cells by themselves are procoagulant. So they marginalise the platelets, and just giving the blood itself, you know, reduces coagulopathy. So even coagulopathy is very uncommon. So we just finished a study on with Jan Janssen at the University of Arizona, and we're using blood component therapy, and it was meant to reduce the mortality in the first 6 hours from bleeding from the mid 25% down to at least 10%. But the overall mortality out of 126 trauma centres in the States, in the United Kingdom and Australia from shocked people who are getting massive transfusion protocols was 7%. 7%. So the mortality from acute bleedings dropped dramatically just because we've changed our resuscitation protocol. So I think that's a good point that you've made. Yep.
I think that's why, you know, that's what we address it's a teamwork, take a nation. we had to really go to physiological detail. It doesn't matter to me, and I will prove it. If you do fresh whole blood and really component with all the factors, we give platelets right away. So this is a major factor for us. If we are delaying 45 minutes of PCC, you need it, we can use PCC instead of plasma. So, you stabilize those patients, and really they don't, like you mentioned, we don't have a death from exsanguinated pelvis. You may have a death from the destroyed liver grade 5 or 6 that is going to die anywhere. But in those patients, and the other thing is, remember, this C is only applied if you don't have traumatic brain injury. If you have traumatic brain injury, you have to really quickly address the airway, the KPIs to prevent secondary insult of the brain, good oxygenation, and avoid hypotension.
I should just add something else. I mean, we're lucky. I'm not too sure what it's like in Sri Lanka, but 7% of the Australian and North American population are universal donors. And so you can have a very good centralised blood service with low T-to-A negative. If you go to China, Japan, Korea, it's 1 in 250 patients, and they call low T-to-A negative blood panda blood because it's so uncommon. and so there's a lot of, you treat this completely differently there because you don't have the blood availability and you would have to treat it surgically.
We're lucky in Qatar because we have probably 70% from this region. And in Qatar, so they really donate. They're incredible. They come by buses to donate in our National Trauma Blood Transfusion Center. So we have, probably like in any place, sometimes the most difficult thing to find is the platelets.
Yeah. What's blood supplies like?
Yeah, your blood supplies.
Actually, I can't exactly say the percentage, but I don't think it's as rare as panda O negative. And then we have got quite a lot of donations, blood donation campaign, which is very widely practiced. So I think most of the time the blood is available, even when we need O negative blood.
In our trauma center, in our general hospital, we have 400 units every day, minimum, baseline. So this is an incredible, I'm so proud of what we have accomplished as a team. This is really, it's a tight business that we have to follow.
I think we have a very decent blood bank facility. Even in the East Day attack, there was no shortage of blood bank facility.
Well, we don't have shortage of blood, as I think probably in Qatar we do have a lot of blood supplies, and unless there is some shortage of unusual shortage, but compared to your country, we don't spend so much of money on 1 unit of blood. You said $1,000 per unit of blood. Yes. I think it's a fraction of that in Sri Lanka.
It's a lot. 1 unit of blood in Canada is $500 Canadian. In Qatar, it's between $700 to $1,000. It's not cheap, by the way. Blood is not cheap anywhere because the quality is the issue. Yeah.
I don't know the exact cost, but it's not so high. I'm not quite sure it's not so high.
Where I come from, the Dominican Republic, you have to go to the station if you want more than 2 or 3 units of blood. This is horrible. This is a shame for the government that cannot provide, blood to the public. So for me, this is unacceptable. We have to have blood for the people.
Moving to our case, following a CT, the patient became again hypotensive and tachycardia suggestive of the further bleeding. So what would be your next step in this patient management?
What I told you before, besides saying that you're really nice looking, you're a great presentation, he has to go to the OR. I told you that before, no? He has to go to the OR because this is the way to do it. You want it, first of all, if you have limited resources. Now, if you have 24/7, I can do angio like in Qatar, but you have to know where your availability, what time of the day he came. They may do another procedure and he's not available. Yeah. You see, they may be doing another spleen from you. This is the second spleen. See, all of these things is in factor. It's a logistic approach.
Yeah, so since we're running out of time, I'll quickly say what happened. He went to the theater and he had a obturator artery ligation. And yeah, can you move the next slide?
These were the laboratory findings.
Yeah.
So there was a grade 2 splenic laceration with small amount of free fluid, which was stable, and there's a large retroperitoneal hematoma which is not expanding and non-pulsatile. Then there was a large pelvic hematoma with active bleeding from the left obturator artery. So this is the operative findings. You can see the pelvic hematoma with the active bleeding.
Yeah, actually, initially we packed the pelvis. We did the preperitoneal packing. Yeah. Yes. So we did the laparotomy, and then we went into the preperitoneal space, and we packed the preperitoneal space. No, the same surgery, during the same surgery. But even with packing, we were not able to control bleeding. We saw that there was continuous soaking of our packs with blood. So then we decided to remove the packs, and this, luckily we were able to see the bleeding obturator artery. We ligated the obturator artery, and patient became stable afterwards.
Yeah, I think that's a really good example. Like in our system, the problem is there's this big reliance on interventional radiology. I mean, there was a question that you put up there about the hybrid room, the hybrid OR, and I think like we're really lucky. Like we have our dedicated trauma OR as a hybrid room, and so we probably would have taken it, but this is a great example of like where surgeons kind of like, they have their plan in mind. You know, this is a positive fast, so they do the laparotomy and they go, oh, there's not that much blood and the patient's still not doing well. Where's IR, where's IR, where's IR, right? And they don't have the thought to actually operate. Like, you know, there's nothing wrong with like a 3-O-proline, right? You know, like it stops bleeding, right? And so I think this is a great example of that you can, even though people say, oh, you shouldn't like, you know, control pelvic bleeding surgically, you can. And I think this is a great example of that. And I think that for a lot of surgeons, that you kind of forget that you can do it, right? And we sort of fall in that trap of, because IR is so available, certainly in our institution, that we rely on them a lot, so.
Yeah, for the trainees, so what do you think? So not regarding this particular patient, if you get a patient with active pelvic bleeding, where the embolization, so your hybrid theatre facilities are not available. So in that case, if you decide to go for preperitoneal packing, so when do you decide to go for laparotomy and preperitoneal packing? So how do you decide?
Well, it's pretty straightforward. Like as an pod fast, they need a laparotomy because potentially the abdomen is the part that they're going to exsanguinate into. Again, I would say that for the pelvic bleeding, it's very rare nowadays, right? It's only if you have this ongoing bleeding artery. And I would suggest that pre-peritoneal packing isn't going to help you much if you have like an arterial bleed. Like it's sort of, we used it previously as a bridge to interventional radiology because across the world, like even in the US, like at you know, Memorial Hermann and at Shock Trauma, it took them like over an hour to get angio, right? And so we used it as a bridge because we could get to the operating room in 15 minutes. But if you don't have a bridge, you may as well just operate. Like if you got arterial bleeding, you got to control, you know, proximal control at the infrarenal aorta at the bifurcation, then just, you know, get down into there. So I think that's, you know, this thing about deciding what to do. If you don't have IR, you don't have IR. You still got to stop the bleeding. So, yeah, I think it's a great example.
It's good. When we came to Qatar, you know, we used to do packing. Now we barely do a preperitoneal packing. And it's because most of the story from Moore, with a lot of egos and everything, is because the resuscitation was poorly. Now the new resuscitation, those patients you can control with the binder, you know, 90–95% of the bleeding. By the time that you control it, IR is with you, and most of them, actually the best story is with angioembolization, you know, because you could be selective and so forth. But I tell you, medicine is an art. You go by physiology. Some patient doesn't read the book. And the best KPI or key performance indicator is an experienced team. Yeah. You know what it works in your hospital. You know what it works in your country. You know when you tire and ask for a second colleague to come, please, Dr. Sue, come and help me, you know. I have the flu, I just came from Boston, you know. I barely can see anything. I have the SSS, the Sri Lanka Spicy Food Syndrome. Okay? I cannot do anything.
One thing that we do at my institution is, as long as the bladder's intact, and you can usually see it on ultrasound, we fill the bladder. So we put a Foley catheter in an aseptic technique, and we'll put in 800 or 900 mils into the bladder, even as a temporising gesture. But we've got a few cases now, and we've published one recently, where you're doing a CT angiogram subsequently, and there's no extravasation. You decompress the bladder, and the contrast comes out of one of the, often is commonly the obturator or adjacent. So it's not a definitive procedure, but it does buy you time, particularly if you've got limited blood supplies or there's a delay getting into the operating room.
I think the best way and the most people work about surgery is to not do harm, And what is the problem with the laparotomy? It's nothing, the most that you can get is a little adhesion. You're not going to do anything. When I come up to this business with my father, we didn't have a CT scan. We had to do a lot of laparotomies. And what is the issues, But we save the patient. Okay, if it's something that is manageable, it's okay. The worst thing is that you have an insult, you have a severe, secondary damage to the brain because you were waiting for something.
Yeah. But it's interesting because I think Jerry's talking about this previously, relating to it. So in North American countries, places like Colombia, there's a lot of operative surgery if you've got a 40% penetrating trauma incidence. And people like Maddox, who was a vascular surgeon, could get into anything because of that. But in countries like Australia, where we get a very, very low incidence of high velocity penetrating trauma, there's not a lot of operating. Like I said, out of the 10,000 trauma patients that we admit per year, there's 120 primary laparotomies. And for the 120 primary laparotomies, 110 are for blunt trauma. And there's 18 surgeons on the roster. So maybe once every 2 years, a surgeon will be doing a laparotomy for penetrating abdominal trauma. So it just depends often on the exposure and skill of your staff, and you have to take that into account, I guess.
Thank you. So we'll move into the next case scenario. So Dr.
We have the last case, will be presented by Dr. Ashan Jaivik, Trauma Registrar.
Good afternoon, everyone. This is also one of the cases we manage at our unit, who was presented with the open abdomen and following a blast injury. So this patient was a 25-year-old male who was brought to the accident service resuscitation room with the open abdomen following the nitrogen gas cylinder explosion. So this was happened 30 minutes before, and this is the initial, this is the appearance of the wound. So in the trauma bay resuscitation room, patient's airway was patent, and he had equal air entry with spontaneous bleeding, and saturation was maintaining. However, his blood pressure was low, and his tachycardic and GCS was maintaining, and there was only a single wound which is on the abdomen with bowel evisceration and evidence of fecal contamination. So my first question to the experts, now the patient is in the trauma bay, and what are your immediate management priorities in the resuscitation bay, and would you proceed directly to the theatre?
Okay. This is almost all the bowel is on the outside with the fecal contaminations. First, physiology, you concentrate on the physiology. At the same time, take to the theatre, the theatre. That is a only simple way. We can't, with the fecal contamination, all this bowel is out, right? We can't do anything in the theatre. But you concentrate on the physiology is important. That's important. Throughout even side to side, you can do that surgery, and it's blood transfusion and everything. You have to do that. That is the thing. We got no other choice. We can go for the theatre is mandatory for this case.
Even though Dr. Peralta says that medicine is an art, my artwork is like a square every time. And this is the same thing. Like, this is a blast injury. I don't know if there's lung injury. So I want to do exactly the same things that I do for every patient, right? Everything. So we've got the primary survey. I want to get a chest x-ray. I want to see the pelvis x-ray. I know what's happening in the abdomen, right? But I want to see all of that and get a blood gas and start resuscitation, all the standard things. There's no doubt that this patient needs to go to the operating room, but I think that this is why we do the same things the same way for the patient, so you don't miss things. And that's sort of where I would go with this.
I think this is the cyanide chemical, right? What's the name of chemical?
I would run away.
What is the chemical?
This is actually industrial trauma where the patient has kept a
nitrogen
gas cylinder.
Okay.
Yeah.
This is a nice example. Also I think it's nice to have a protocol for direct or the right theater things for some other injuries, like impalement or something like that doesn't have, secondary insult. This hypotension could be for tension pneumothorax if you don't see. You can have bilateral tension pneumothorax and no tracheal deviation and have a blood pressure like this. We've seen it before, tympanos, all of the issues. So if we are now in the trauma bay, I think it's quickly, we can do it. Don't spend more than 30 minutes and go to the OR.
Yes, so as you correctly said, we rapidly resuscitate the patients with IV fluids and blood, massive transfusion protocols, and we rush to the theatre for the damage control surgery. So we performed the laparotomy. So the findings were there were multiple enterotomies. Not only enterotomies, there are multiple fragmented bowel loops, transected bowel loops, mainly in the small bowel as well as in the transverse colon. And there was a penetrating kind of injury that the bladder was shattered, extensively damaged, and as this is the diagram of the bladder, the foreign body has gone through the anterior and posterior wall and impacted in the left side iliac bone, the metal particle. We had queried whether there's an underlying fractured bone also. And at the same time, there was evidence of fecal contamination with the hemoperitoneum from the mesenteric tears. In this complex scenario, you are in the theatre, so what are your priorities under damage control surgical principles?
So the main priorities are, as for all damage control surgery, so stop bleeding and resuscitate the patient and minimize the contamination. So this is the aim of damage control surgery. Here we could control bleeding, mesenteric bleeding with ligation, and we pack the pelvis. So the peritoneum was breached, so there was no pelvic peritoneum which is breached. So we pack the pelvis and then we stop bleeding from the mesentery. Then,
yes. So in the laparotomy, to achieve the hemostasis, the abdominal packing mainly the pelvis was packed and the mesenteric vessels were ligated. And for the bladder, the wall was we performed the hemostatic ligation. For the contamination controlling, So multiple enteromies were controlled initially with the soft clamps, and subsequently we ligated them, and the foreign body was retrieved. However, towards the end of the surgery, we noted that there are multiple dilated closed loops are developing in the small bowels. As I said, the bowel was transected in multiple sites with intact mesentery. My next question is, would you try to perform a primary anastomosis here?
No way, sir. Thank you.
Yeah.
You know, no way, sir. If you go to the physiology, remember, do this dictum, don't get more than 90 minutes in this OR, just go back, resuscitate, and you may need 2 or 3 times, coming back for washing. He is severe contamination, probably in the chest and in the bladder too. So this is the issue that can kill is going to be the sepsis or missed injury. It's not the bleeding at this moment, it's not bleeding. But detail follow-up of your protocol for this damage control or surgery, and then just calm down. 24 hours, 48 hours, you can come back. Actually, I will do it 24 hours because of the bowel injury. And the other thing is one thing what the bowel tell you right now. One thing is tomorrow, because those are expansive type of injuries, and this bowel is full of air.
Yeah. So, however, assessing the degree of the contamination and the hemodynamical instability of the patient throughout the surgery, we took a collective decision to perform the anastomosis. However, to reduce the time, we had to cut down the multiple fragmented bowel loops and reduce the number of anastomosis up to 2. So at the end, we performed one end-to-end jejunal and one end-to-end ileo-ileal anastomosis. At the same time, the transverse colon was exteriorized. The enterotomy was exteriorized as transverse loop colostomy, and because of the extensive damage to the bladder, so the bilateral ureters was exteriorized. So we did the temporary abdominal closure with skin only, with abdominal pack inside too. And because of this additional operative things, the time was exceeded up to 3.5 hours, and blood loss was 3.5 liters. But patient was managed, patient was actually hemodynamically stable at that time, and the patient was sent to the ICU to continue the resuscitation and monitor the physiology.
Let me ask you this. I like to teach, but I'm more a student than anything else. The dictum's around 90 minutes. You can go to 2 hours. I think we're doing a lot of procedures because we don't know tomorrow how's the viability of those tissues, including the anastomosis is there, and you risk the patient. This is something that I never understand, no in English, no in Spanish. What is stability for you? Because we have an incredible anesthesia team. Stability, they are with vasopressors. They say that they're stable because you see a MAP pressure 65. They're not stable. They are with vasopressors. So you have to you understand what is a stability patient. This patient needs to get out of there quickly, resuscitate in the ICU, and then come back multiple times. This is my way to do it. By the way, if you get away with this, you are lucky, and it's good for the patient. But this is not the way that those patients behave. You want to say something?
Yeah, I'd abbreviate the operative procedures and get a CT scan.
4 hours.
Yeah, I mean, it's, you've done a lot of that could have been delayed. You just want to crack on and see what else is happening.
You have a better English than me, okay? Are you agree with what I'm saying or no?
I'll say it clearly, yes.
Yeah, so after a couple of hours during the post-operative period, we noted there's a persistent oozing from the abdominal wound. By that time, patient has developed some acidosis, and there's a coagulopathy. Patient was on massive transfusion, and he was awaiting the thromboelastogram. So, in this context, what would you consider in managing ongoing post-operative bleeding? Are you going to perform the imaging or get the help from interventional colleagues, or I will straight away take the patient back into the theater to achieve the hemostasis?
Only the blood product and the resuscitation. No, we can't do anything. These are new things. Can't find it, the new imaging or anything at the moment. What do you think?
The patient was
my last, yeah.
Patient is straight away sent from theater to the ICU.
Yes,
but
after 4 hours.
1 or 2 hours.
After 4 hours, 3.5 hours. We'll do that. I tell you, I just gave you a lecture. You know, coagulopathy comes in different wave and shape. One other thing for this lethal diamond is pH. If your pH is really low, none of the factors going to work, okay? We have to correct this. And I don't want to hear fluid there. I just want to see blood. I see saline, 7 liters of saline. Check it out in the back. Saline 7 units, is 7 liters, it's too much. This is not good.
Yes.
This is not good. No bueno in Spanish, no good, okay? We cannot do that.
No
bueno, no bueno, no good.
So the reason for skin-only closure, is that something that is routine here in terms of temporary abdominal closure, just skin-only? Like, I know Shamila talks about it and has published on it and seems to really like it, but we're lucky we have the Chathura, which is, but you can make that, like, as in just a temporary abdominal closure. I'm just curious as into why the choice of skin-only closure. Is it because you made a stoma, or like and a ureterostomy? Is that the reason, or is that standard practice to do skin-only closure for temporary? Because obviously you're planning to go back, right? I'm assuming.
No. We don't have that here.
I know, but all you need is a bowel bag and some packs and a couple of drains and some sticky drape. That's all you need.
So most of the time we don't have even this Bogota bags even here. So we use locally made abdominal closure techniques like temporary closure with URI bags and all. So we don't have it.
In a Bogota bag, Colombia, they had nothing. They just cut a urology bag, a 3-liter bag.
Yeah, that's what we do here.
Kind of
the
thing,
same thing we do here.
I'll give you an example. There's some US Marines based up in northern Australia, and one of them's injured in a helicopter crash, has his lung removed, comes down on ECMO. He's got a fractured tibia. He's on ECMO for 6 weeks. You know what nearly killed him? Was the fungal infection he got from the small wound with the small bit of shrapnel that was ignored after a week of antibiotics. And he got this multiple fungal infections, which eventually settled down with GCSF and hyperbaric oxygen, all sorts of things. So these sort of blast injuries, you have to pursue every component of it and make sure you're not missing anything, and that there's not a focus of infection, that you've examined the whole patient with a CT scan.
You know, I was thinking about, I should not go to the personal level, but I tell you, you know, it's a utopia, it's a naiveness that you think that you're going to control this massive injury in one OR. Why you spend 3 hours and a half when we can do 37 minutes, 67 minutes, control everything, come back every 12 hours, every 24 hours. He will declare this thing is an explosive and expansive injury. It's not going to get away right away unless we're lucky. But this is not the way that we're going to teach. I cannot teach by one lucky case. I have to teach to be safe. And safe is expansive injury like that, you know, we have to respect.
Okay. So, depending on the expertise and the time, actually we had to we had to actually the patient take back into the theater to control the bleeding. Actually, there was a new findings. There was a 500 cc amount of blood clot inside the bladder, and there was a bleeding from the periprosthetic venous plexus, which was not noted initially. So again, we did the repacking of that area, and then again temporarily closed the abdomen and send the patient to the theater. So in the post-operative day 1, patient was, the acidosis was complete, acidosis was improving, and the coagulation was also correcting with the thromboelastogram, and we completed the secondary and tertiary survey, and we performed the CT. However, there was ongoing bleeding from the surgical site. And in the imaging...
Sorry, could you go, sorry, 1 second. Could you go back? Okay, no lethal triad, lethal diamond. We had to use calcium. I just gave this lecture, okay? Take me, what, 10 years to develop this concept? So I remember, if you don't do this with so many blood products that you give it, you don't give it calcium, you're not completing, you know, you're not optimizing the treatment of this patient. Remember, just in that particular point, okay? I don't care what the rotten tell you. I have a friend, my colleague, that loves rotten. I love tech, but we are wrong, because you take the sample of this gentleman to outside of the body and you do a test. You think it's the same thing that is in the body? No way. It's a physiological issue. You have to think about the pathophysiology of those diseases. Trying to correct as much as you can. Why are we doing this? Because we develop iatrogenic coagulopathy. Now this guy is bleeding, 500 disease. He shouldn't be bleeding if we leave it like that. You will have necrosis, but no bleeding. Now we have necrosis and bleeding, okay? So let's try to, improve the coagulation and the regimen correction with calcium. Every 2 units or every 4 units of blood, we have to give a calcium to the patient, okay? And if you have a pH is low, you have to give calcium to the patient, and so forth. Thank you.
Yeah. So the CT showed that there's a left side acetabular fracture with the contrast extravasation deep to the obturator muscles. However, they said there's no arterial bleeding, so they are suspecting could be from the fractured underlying fracture or a venous origin, and no solid organ injury. So these are the CT images. I will move forward because of the time's constraint. So day 2, the patient was still intubated, hemodynamic stable, ongoing oozing is there with correction of acidosis and coagulopathy, and because of the hemodynamic instability, we decided to manage conservatively at that moment and repeat image before the factor removal. So next question is there...
We'll go ahead because we are going behind the time, so shall we close?
So...
you can show the last few pictures.
Yes. So actually, this is the presentation of the patient, and after extensive workup, we managed to achieve this outcome during the day 12, post-operative day 12, where we the remaining problem was the managing the wound and the urostomy, the problems. Actually, we have a video of this patient where he explained his experience and his the outcomes, and we will take a moment to hear what he, in his own words, what it meant to meant to survive and recover from this kind of extensive damage.
On the back.
Okay, so I think we are behind the schedule, so we'll stop this.
So we'll wind up the session, so you can see him behind talking about 3-4 months later. He's talking about his experience. Thank you very much, the expert panel, for that wonderful contribution.